Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Barry Raphael. Dr. Raphael has been practicing orthodontics since 1983. Over that time, he has developed a treatment approach designed to address airway-centered dysfunctions, such as sleep-disordered breathing, in an effort to minimize their impact on facial growth and thereby reduce the incidence of malocclusion. Dr. Raphael now teaches these techniques nationally and internationally with the Airway Collaborative, an educational and consulting consortium whose mission is to teach patients, parents, and professionals about airway-centered dysfunctions and treatment alternatives. Dr. Raphael developed the first graduate program in myofunctional orthodontics at the Mount Sinai School of Medicine and now lectures in the departments of pediatric dentistry and orthodontics at the Montefiore School of Dental Medicine, as well as the Setor School of Orthodontics in Hoboken, New Jersey. Today, we're going to have an amazing discussion about pediatric airway health and how that ties into overall health. This is going to be a fascinating episode for professionals and lay people alike, and you're going to pick up tons of pearls and insight into why people such as Dr. Raphael and myself have gone on this journey. So without further ado, let's get on to my conversation with Dr. Barry Raphael. Enjoy the show, everybody. Welcome to the Doc Podcast, Barry.
Welcome. Really glad you had me on your show. I've really been so impressed by it. You have a lot of my predecessors. You have a lot of my students. You have a lot of the people that I've been standing shoulder to shoulder with over these past 15 years or so. And I'm just happy to be part of your collection now.
Well, I'm humbled by that to be someone that you enjoy listening to, as you are a very big name in this arena. Going back years ago when I started on this journey, your name came up from so many people. Like, do you know Barry Raphael? Have you met him? Do you know him? You guys need to speak. And we got to meet in person earlier this year, not too long ago, actually, at the PANI meeting that Steve Lamberg does an amazing job with on Long Island. So it was great to see you and meet in person and hear you speak, and what a great speaker you are. And we were commenting in the audience that you did an amazing job, and I think I even told you afterwards, condensing really, really complicated material into a pretty short period of time that we had to speak, and making it very easy to comprehend. And that is a gift as someone who teaches and speaks for a living. It is not easy to do. So you have a really great ability to do that. And I can see why so many people gravitated towards your approach and your educational style.
Well, as someone who needs to think of things simply and to understand them, my approach has become just a necessity of the way I have to learn myself.
Well, it shows. So tell the audience, you're welcome, a little bit more about you, who you are. You've been in the profession. You started in practice, I believe, early 80s. So tell us a little bit more about who the Dr. Barry Raphael is that maybe we don't know and don't get to see.
Well, I am the son of an orthodontist, and Dad taught me to trace a Sunni when I was in junior high school. I learned to carve models for summer work. Mm-hmm. And I did tell him when I was, I think, in 8th grade that I'd like to be an orthodontist. Now, I did stray from that for quite some time. Thinking that, number one, I wanted to be a musician. You can see my axe is still hanging up on the wall. Yeah. I don't play that much anymore, but I am one of the original members of the Pulmonauts, if you've heard of that little project.
Oh, yeah. I've gotten to hear them a couple times in person. It's been really fun.
That's gathering of a number of the people that are in this arena who also play, and we got together. We played our first gig was at the PANI event, as a matter of fact, maybe 3 years ago. Okay. We had James Nestor as our drummer, And music's still close to my heart. But when I got out of ortho school, I got a job as a few spots as a general dentist.
Okay.
Working in the clinics, just trying to figure out what I wanted to do. But at the same time, I hooked up with a college friend of mine who would later become Grammy-nominated artist. His name is Jonathan Sprout, did children's music for many, many years.
Oh, wow.
And but I had practiced dentistry 50% of the time, and we were doing original music 50% of the time.
Wow.
I would say that the joy of music sort of started to fade away when I had to make money from it. And at the same time, my dad was saying, you can do whatever you want to do, but I'm getting to the point where I need to bring somebody into this practice. And I thought twice about it and decided that I would go back in to orthodontics. I went to school at Penn for dentistry, but did my orthodontic residency at Fairleigh Dickinson, the now defunct Fairleigh Dickinson, because it was close by, and I could work with Dad on the weekends while I was doing my residency. My 3 years in general dentistry, I thought, really were helpful for me. At the time, there were no general practice residencies to go through. I did my own general practice residency in the real world. And it really gave me a feel for what was important. You don't always really understand that when you're in school.
True.
All the extraneous things. How do you communicate with patients? How do you do treatment plans that they're going to accept? How do you deal with someone who wants you to do as many procedures as possible in as short a time as possible, when you may or may not think that that's the right thing to do? There's all those kinds of challenges. But I came away with at least an understanding that I enjoyed dentistry, enjoyed working with my hands. At the time, at least a couple of the jobs, there were, they quickly started sending me the kids because I liked working with the children. And even though I didn't have a specialty in pediatric dentistry, it was something that sort of came naturally to me. So I was doing that. Eventually, I left the band and went back to Fairleigh. Now, what Fairleigh was good for was that in that residency, we had 14 clinical instructors, and I learned 14 clinical techniques.
Wow, 14. That's amazing.
Yeah. It was everything from standard edgewise to beg to straight wire to functional appliances. This is back in the early 80s. We even had a course in myofunctional therapy, believe it or not.
That's amazing.
And which may be something we want to talk about, because while I knew enough about myofunctional therapy to use it in cases of mine that were having trouble, it didn't really dawn on me that muscle function was that important until 25 years later.
Yeah, yep.
But I got out of residency in 83. I went to work with Dad, and he gave me two gifts. Number one was he let me do all the treatment planning from the day I walked in. Of course, he would, go through them with me, and he had to develop his confidence in me.
Now, was he practicing a particular type of orthodontics or discipline or philosophy?
Well, interestingly, he was using a combination bracket at the
like
time.
Like an 022, 018, like a bioprogressive type?
Well, it was called the Kessler bracket.
Okay.
And it wasn't even new at the time. Kessler out of Newark was trying to figure out how to get the best advantages between the beg technique and the edgewise technique. And at the time in my residency, Unitech was just starting to come out with their what they called the fourth stage bracket, which was really meant to do beg treatment, but then have an edgewise slot for uprighting at the end, which was really one of the hardest parts of doing beg.
Yep.
And over the first 20 or 25 years of my career, I went through new iterations of combination brackets. There was the cat bracket. There was, there was tip edge, but that wasn't exactly a combination bracket. But there were a bunch of them, and I worked out what I thought was a terrific way of doing extraction treatment, in that I could take advantage of the light forces of tipping at the beginning of treatment. And then you actually use dual arch wires, where I could upright at the same time that I was either closing spaces or whatever it was. However, at the same time, I was starting to understand that extractions were overdone, and by the time I reached the turn of the century, I wasn't really doing extractions more than, 5% of the time.
Anything in particular that helped you realize that?
I think my foray into early treatment was helpful.
Yep.
So I often say that my second most influential person in orthodontics, other than my father, was Jim McNamara. Jim was one of the very first lecturers that I heard out of residency. And my father had a lot of great things to say about him, especially the fact that if Jim didn't know something, he would say so. And if Jim had trouble doing a case, he would say so. And my father valued that as an indication of integrity and transparency. And I've always kind of felt the same way. I'll talk to you about my failures as well as I'll talk to you about my successes. And Jim was certainly influential because he was talking about doing maxillary expansion, not in the presence of crossbite, which was something that many orthodontists still have not quite gotten over, even though the AAO finally, gave blessing to that kind of thinking. I can't remember how long ago it was, but it was.
His paper was in 2000, the maxillary transverse deficiency one that they published. Where he called it hidden maxillary transverse deficiency. I believe he said, the way he phrased it was, it's the most commonly misdiagnosed or underdiagnosed problem in orthodontics. I feel that our academic institutions still, many of them, I'm not painting with such a broad brush that I'm saying all of them, but many of them, and I know firsthand many of them, still don't embrace that philosophy. And I have had department chairs say, we don't trust McNamara. We don't think favorably of Mac. So it's like you can't win because they'll say something about, well, there's no literature, there's no evidence. And then you start talking about all the prolific publications that someone like McNamara has put out there that have been in all the same journals that are heralded as the places you have to put this stuff. And then like, but I don't, but he's wrong. So what about that? Why do you think we are so resistant to this?
Yeah, I'd like to talk about that because I was resistant.
Same.
I spent literally the first 20 years, maybe 25 years of my career towing the party line.
Wow.
And you'll be interested to hear that part of the thing that cracked my brain open was a meeting of the AAO.
Really?
When I became president of the state society that's in New Jersey, I was invited to a leadership conference down in Washington. It's where we routinely bring all the new presidents and kind of give them a little bit of a lay of the land politically, a little bit of an indoctrination into the benefits of the AAO to its members and so forth. But this particular year,
About what year was this?
That's a good question. I think it was 2016, maybe.
Oh, so not that long ago. Okay.
So it wasn't that long ago. I had already started to change my thinking.
Okay.
There was a keynote lecturer. He was a practice consultant like yourself, who would, but not just in dentistry. He was a consultant for organizations, for membership organizations. Okay. And he talked about the idea that every organization is built on certain accepted truths regarding that organization, which he called orthodox beliefs, that may serve the membership very well, or they may have served the membership very well, but no longer do. And that if you're going to move an organization forward, that you always have to be aware of what your orthodoxies are, and you have to be able to reevaluate them. And it could be that some of your orthodox beliefs still hold true, but the ones that don't or are changing in time, you have to be flexible enough to say to yourself, this no longer is serving us, and we have to move on. So at this meeting, I stood up, I raised my hand, I said, I've been going through a major shift in my orthodoxies, and who do I talk to about this in the organization?
Did the room just fall silent?
It wasn't a thread they followed up on. That's for sure.
Yeah.
But that was just 3 years before the winter conference that the AAO had about the relevance of sleep apnea and orthodontics, in which they reinforced the orthodoxies entirely. So
was that the one where Dr. Guimeno was there, and then the next day there was a whole big uprising about what he had talked about? Is that?
Yeah, that's exactly right. And it flew in the face of the 2017 document from the American Dental Association regarding and you're probably aware of this, but that one paragraph in the well, maybe I should say it, in complete so your listeners understand. It was the document from the American Dental Association talking about the role of the dentist in treating sleep apnea. And rightly so, it said that dentists should not be diagnosing and treating sleep apnea because it is a medical condition. I totally agree with that, by the way.
Yep, same.
If someone has true sleep apnea, you don't want them dying on your watch at 3 a.m. when they choke, to death. And we do have a role in helping them out, the physicians, I should say, and the patients, in perhaps bringing the mandible forward or making it easier to place the tongue in the front of the mouth so it doesn't have to fall in the back of the mouth and all that stuff. But that one paragraph that talked about what we're doing for children was, to me, like manna from heaven. I mean, it was the universe thanking us for what we do, and those of us that were already on this road, and supporting us and pushing us forward. So when at the end of that paragraph, should I read the paragraph? Because I do have it in front of me.
Yeah, please. Yep.
I'll do it, because it really is, I think, a critical piece of policy.
I agree. Actually, in many of my lectures, when I give longer courses, I actually show this actual paragraph you're going to read. Yep.
And has anybody read it on your program?
No, not to my. At some point, I've mentioned what they say, but no, I think it'd be great. Go ahead, please read it so everyone can hear it.
In children, screening through history and clinical examination may identify signs and symptoms of deficient growth and development. That's the first phrase. And I'd like to say this. Understanding deficient growth and development is the key. and I know you've reviewed this on your show, that our faces are not growing the way they used to.
Correct.
I know that it seems like everybody who's doing this loves to do palate expanders. And I remember, how controversial that was. That was the kind of stuff that people like John Witzig would do. And us orthodontists, that was another one of many times that I resisted understanding this, because I was, loyal to Jim McNamara. And when Jim McNamara goes up against John Witzig, I favored McNamara, even though the case was about how orthodontics might cause or exacerbate, or rightly so, ignore TMJ problems in our course of treatment, because we just wave it off and we say we have nothing to do with the TMJ. All right. But deficient growth and development, I think, is not just a matter of maxillary transverse expansion. Deficient growth and development lies at the core of why we have crooked teeth. That in history, humans generally did not have crooked teeth until things happened that challenged our metabolism and our physiologic function, that discouraged our faces and jaws from growing sufficiently. All right. So right away, this paragraph set is like right on target. All right. May identify signs or symptoms of deficient growth and development or other risk factors that may lead to airway issues. Okay. So other risk factors that lead to airway issues, this is also manna from heaven, because it has nothing to do with the teeth, frankly. The risk factors that we're looking at are the things that make it hard for us to breathe.
Right.
And that could be allergies, could be upper respiratory tract infections. It can be the swelling of tonsils and adenoids. Which, actually, we also has an epigenetic etiology that we have not recognized. We just thought some kids have big tonsils and adenoids. All right. So all that's really good. Now we've opened up the idea that we have to look for root causes. Okay. Next sentence. If the risk for sleep-related breathing disorders is determined, intervention through medical/dental referral or evidence-based treatment may be appropriate to help treat the sleep-related breathing disorder. So there is now...
Doesn't it go on to say, you may read this, but...
well, I'm going to save that for last.
Okay, all right, save it for last. I was going to say, because I've got, yep, sorry. I don't want to step on. Where our minds are thinking the same thing. I was like that,
exactly.
Yep.
That this intervention through medical/dental referral or evidence-based treatment. Now, we know this evidence-based treatment is the thing that trips us up. Because, frankly, the evidence in the orthodontic literature is scant. In the medical literature, it happens to be a bit more robust. And it's also a little more robust when you look at our orthodontic historical literature, because we understood this some years ago, but have conveniently forgotten a lot of it.
Thank you.
And, right. So even Tom Graber's scathing article in the AJO, the 3Ms, was an enlightened way of looking at the polarization that was going on between angle and tweed, between non-extraction and extraction. And Graber, who was always considered one of our patrons in orthodontics until his passing, was saying that's not the point at all. This whole polarization between, well, I mean, there are us orthodontists, we polarize around a lot of things, right? But extraction, non-extraction, one phase, two phase, so forth. But nature versus nurture. But this idea that there's no evidence, it turns out that there is plenty of evidence, just not in our literature. also this idea of medical/dental referral and treatment is picking up steam now, because even as we, as a society, as a healthcare profession, are starting to look more at root cause issues, we are understanding that there are no isolated parts of the body that aren't influenced by every other part of the body. Mm-hmm. And this is really one of the basic premises of functional medicine. Mm-hmm. And this statement opens the door for the fact that dentistry is not just about the teeth.
Thank you.
It's about a part of the body that happens to contain the teeth, but it is a part of the entire body. Mm-hmm. So I know here in New Jersey, there's going to be a big symposium this summer, which I've been invited to speak at, that will talk about how dentistry and medicine need to come together again.
Oh, really? That's amazing.
That's going to be great. And there's a long history to it, certainly a lot of controversy. In some ways, dentistry did well by separating itself from medicine. Mm-hmm. We are more the captains of our own ship than the physicians are. There are certain things about our independence that we want to maintain, but not from a patient care point of view. We have to be as dedicated to the health and well-being of our patients as are the physicians. Mm-hmm. All right. And then, the medical dental referral, evidence-based treatment to help treat sleep-related breathing disorders or now here comes the biggest part. Mm-hmm. It is telling us that we are responsible for helping, quote, develop an optimal physiologic airway and breathing pattern. Mm-hmm. An optimal physiologic airway and breathing pattern. And Mike, these are the words that I live by now.
Same.
It's my mantra when I am having trouble clinically, when I am working with a kid who doesn't want to be helped, when I'm working with parents who don't understand, when I am faced with knowledge gaps of my own, I fall back on this one phrase here because it is my reason for being. Now, as an orthodontist, I don't say that every orthodontist has to feel this way. Mm-hmm. And there is a metaphor that I want to talk about maybe in a minute, but there will be a place for cosmetic orthodontics. People do like a pretty smile. We want a nice prom picture, a nice wedding picture, all that. But if you're going to be dealing with health and well-being of your patients, understanding that developing an optimal physiologic airway and breathing pattern is at the core of what we do. And we, as orthodontists, stand on the precipice of opening this whole area open to our society's benefit and welfare.
Yeah.
We have a particular knowledge base, thinking pattern, and hand skills that lead to helping children develop an optimal physiologic airway breathing pattern that I don't think any others do.
Yeah.
Yet we lack a certain amount of thinking. You know, it's some of the orthodoxies, and we can talk about those, what our orthodoxies are and what I think we need to change them to be. But this is the one that changed for me the most. And so, I say hang it on the wall.
I completely agree. I'm so glad you brought that up because so often, a lot of our colleagues, until I started on this journey a couple of years ago, I was doing a lot of this in my practice for many, many years.
Yeah.
I didn't even know that position statement had come out. You would have thought that the AAO and our leadership in the orthodontic arena would have championed that and said, look what the ADA did, and played off of that. But Barry, it's almost like they doubled down on their orthodoxies of the tradition. And one thing that, yeah, exactly. Barry's holding up the vampire cross, get away. But one thing, it was interesting. I was listening to a podcast recently, and a gentleman was talking about the psychosocial implications of our tribes, our groups, right? We evolved from tribe culture. You had to fit in to a certain extent. Those who varied from the tribe, the consequences were grave, if not fatal. Yeah. And that's within us. And so you see people in these tribes, and he was using it, obviously not relative to orthodontics and airway. This wasn't an orthodontic or dental or medical discussion, but it was relative to, he referenced specifically politics and religion. Yep. And I thought, wow. And that's why it's so interesting you brought up the fact that we have these orthodoxies, because I've been thinking for a long time, and I say, and you've even heard me say, as frustrating as it is that a lot of our brethren, especially the more established ones who have been doing this for many, many years, and I give you tremendous credit for having done this for 2.5 decades and been able to modify, because that's very rare, and that's about what I'm about to say proves that. When you've gone all in on something, and I want the audience to understand this, and I want to hear your thoughts, because I think it's at the very core of what we're dealing with. Everything you said I agree with. There is science. There are data, tons of evidence out there to support everything we say and do, those who think like we do, in a more functional approach, a more proactive approach, a more whole patient, holistic approach. Yet you say this to people, even back to what we said before about McNamara, and here it is in the AJODO talking about this transverse deficiency, and they will stand there and say, you never expand in the absence of a posterior crossbite. It has to come down to the psychological implication of asking somebody to abandon their belief system for such a long period of time. No different than if you ask the leader of the Catholic Church to embrace wholeheartedly Judaism, right? Or become a Muslim. Yes. You could present all the evidence to the contrary that you wanted to. They would be blind to it because it's self-protective. And I really feel like, as I've dug so deeply into this and interviewed and spoke with so many people and immersed myself in academia, and I'm seeing this, certain people, literally, it is their religion, it is their politics. They will not allow any evidence that is presented to change their mind. Do you agree with that?
I do. And boy, we can really get into a broad discussion here, because there is a philosophical underpinning to the way we view the world. So I don't want to get into it too much, but in college, I wrote a paper based on the Heisenberg uncertainty principle in English class. It was the only time in my whole life I got an A on anything in English class. And the Heisenberg uncertainty principle, of course, looks at the properties of light, that it can be viewed as a particle, as a photon, a discrete packet, or it can be looked at as a wavelength, so various wavelengths, different colors and so forth. But what Heisenberg showed, and mathematically so, was that you can never look at light as both things at once. And so that's the yin and the yang of our existence. Both things are true. They never can be true at the same time. What you see depends on the way you look at it. So, gosh, it's not just an orthodontics. Look at our political situation, how we're polarizing still. And so I did bring with me this one meme from Albert Einstein, which I think is particularly helpful here. And let's explore it just a little bit. He said, "We cannot solve our problems with the same thinking we used when we created them."
Love it.
So just to be specific, when we look at this argument of extraction or non-extraction, when we look at this issue of one phase or two phase, when we look at this issue of transverse expansion with or without a crossbite, those kinds of polarizations will never, ever be solved by arguing one against the other. They'll only be solved if we start thinking about the problem differently. And so I know when you saw my lecture at PANI, I was highlighting the broad scope of treatments that we can offer, all the way from natural healing to orthognathic surgery and everything in between. And in that concept, I had orthodontics off to the side in a sliver of a column compared to everything else. Because this problem is not an orthodontic problem. A lot of people have been very critical of orthodontists, and orthodontists have become very defensive about that kind of thinking. By saying that orthodontist has nothing to do with airway, and orthodontics has nothing to do with TMJ, and orthodontics has nothing to do with profile. And mostly I agree, because if you are taking out teeth, taking out 4 premolars, because the crowding is so severe that you can't find out any other way to do it, you're not going to be causing an airway problem. The airway problem is already there.
Thank you.
And you just didn't see it, or don't see it, or don't want to see it, or are not looking for it.
Yep. In the lecture I gave, it the Orthodontics 2.0 versus 3.0.
Yeah,
right?
I love that concept. That's exactly right. Orthodontics 3.0 is going to be looking at the underpinnings of not only the airway problems, or not only the crooked teeth, but both and more.
Yeah. Because
we're now having to look at the entire body, of which the crooked teeth are just a symptom. They are not the problem. And that's when I list the orthodoxies that have changed, that's the first one.
Yeah.
You know, my dad was an orthodontist. I went to orthodontic school. We all went to orthodontic school thinking the problem is malocclusion, the solution is braces. But the crooked teeth are really not the problem at all.
Right.
They're just the body's way of telling us that there is an imbalance.
Yeah, they're the symptom.
And it's a symptom. There's an imbalance in the mouth. There's an imbalance in the posture. There's a balance in the breathing. Something is out of whack, because humans never had crooked teeth before this. I say before this, past, the modern era, the industrial era, 400 or 500 years ago. The anthropologists have been trying to tell us this for years. Right.
And we read the Coracini studies. And
I don't want to hear Coracini. I don't want to hear Melvin Moss.
Right.
I just
Barry had his fingers in his ears for those listening on audio while he was doing that, the petulant child not wanting to hear their parent or their teacher, because that's what it feels like. It's like when we talk about this, it makes such sense. And the thing meaning that this philosophy or this approach makes such sense, to try to be proactive, preventative. I know it is a paradigm shift, but it still is extremely logical. That being said, people will fight against it so fervently, and they are putting their fingers in their ears and not wanting to hear any of it, because it threatens their reality and their way, it threatens their existence, and it threatens their orthodoxy, and nobody wants their orthodoxy to be threatened. And I think that I love that you said that, and it's something I've been trying to say as much as I can as well, because there's this whole debate that goes on in these ortho groups. We have a lot of non-orthos who listen. So just to give it a little background, there's some orthodontic study groups online, And one of the common themes is this whole debate of whether extractions cause airway problems or not. Right. And I always say what you said, which is, I have never said that extracting teeth, that you walk into the oral surgeon and they take 4 premolars out and that night you have sleep disordered breathing or sleep apnea. That is not what's going on. No. Oftentimes, as I showed in that case at Pani, that little guy that I treated 20 years ago in the very beginning of my career, when I had no idea of any of this and was just an orthodontist, I was trained to look at and straighten teeth. Yep. I took him down a serial extraction pattern without any awareness of anything outside of this guy's teeth, and his canines were bearing down on his laterals, and he's 10 years old, and I'm like, I got to get some tooth mass out of there for this little guy. I miss the dark circles under his eyes. I miss the transverse deficiency. I miss the high vaulted palate. I didn't have CBC at that time, so I didn't notice what I saw when I ended up finishing his case and I had CBCT, which was incredible turbinate hypertrophy and nasal passageway obstruction, asymmetry in the sinuses, maxillary sinus hypoplasia on the left side, enlargement of the lymphoid tissue. I saw none of it. Right. So I didn't cause his problems by taking him down a serial extraction pattern. Right. I just missed it and focused on his teeth.
That's exactly right. That's exactly right. We missed it because we weren't looking for it. It wasn't really on our radar. We needed a different way of thinking.
Yeah.
So the thinking is more now outside in rather than inside out. You're looking at the whole person first. What are their quality of life challenges? And we know, gosh, that chronic non-communicable diseases of civilization are overtaking us in ways that are affecting our survivability as a species if this trajectory continues the way it's going. I don't think we'll let it quite continue that. Or if AI is going to really take over the world, it will be because we are no longer viable enough to maintain ourselves. Maybe that's just a little bit too abstract thinking. I've been listening to all these podcasts about AI. But the truth is, our kids are getting sicker, and they will not live as long as we do if their chronic diseases cannot be solved in a substantial way. I'm sure everybody has heard, that 75% of our kids are not eligible to be in the armed services because they're just too weak. They're not resilient enough. And I see it in my practice, maybe because I'm attracting these kinds of kids, but the number of kids on the spectrum, the number of Down kids, the number of kids that were born prematurely or that had congenital problems is increasing. You've heard
ADHD as well. So many kids.
Yeah. And it does require looking at things in a very different way. So, I could probably go through 10 different wake up calls that happened for me.
Give a couple examples, please, because I think it'd be good for people who are out there on this journey, questioning this. They hear people like yourself or myself. They think, well, maybe there's something to this. Yeah. They just don't know how to suspend their reality a bit and see things differently.
Yeah. And I'm not saying I'm any more intelligent than anybody else.
No, nor am I.
Many of these things took a while to brew.
Yes.
Before they finally, it dawned on me that I had to look at things differently. I call it my Zen fool's moment because the fool in Zen is akin to the empty mind, where you have to clear out a lot of the old thinking in order to make room for new. So I credit it to an open bite case that I had, where I'm using vertical elastics and tongue spikes to close an open bite on the right side of the occlusion. The premolars, the canines wouldn't come together no matter how I pulled. And of course, I'm blaming it on the patient. They're not wearing their elastics, blah, blah, blah. And I sit down to lunch, and I read an article by your last guest. I think he's your last guest on this podcast, Herman Ramirez.
Mm-hmm.
And the article is about the use of the trainer system, the myofunctional research company's exercise device. Mm-hmm. And but he says in this article, he says, soft tissue dysfunction is the etiology of malocclusion. Mm-hmm. And I go, all right, yeah, I know it's a tongue thrust. And I know that kids that suck their thumbs are going to screw up their teeth. Mm-hmm. And I know pacifiers are going to make problems for kids. We all sort of recognize that. But to tell you the truth, I didn't really understand it because I thought those were isolated things. Mm-hmm. But what he was saying is that generally, if you see crooked teeth, it's because the muscles have made the teeth crooked. Mm-hmm. And that brings up another polarity, in our thinking of nature versus nurture.
Yes.
I mean, the British Dental Council just recently gave an edict against an orthodontist on the basis that malocclusion is entirely genetic.
Genetic, yep.
How could they say that?
I don't know.
When we understand so much more about protein synthesis and DNA transcription to understand that DNA is just a blueprint, perhaps, mm-hmm. but its expression is entirely influenced by input from the environment, not just on a grand scale, on a microscopic, biochemical, bioelectric scale within our bodies. Each membrane of our cell is interpreting its environment and translating that into different ways of expressing protein synthesis. Mm-hmm. And depending on what system that cell is in, that'll change the outcome, the phenotype of the cell or of the organ. I've even come to the point where I think the angle classification, while a useful phenotype, has been entirely misused by our profession. Mm-hmm. It is not a separate nosology. It is not a diagnostic criteria. Mm-hmm. It is not the best paradigm. It is not the best paradigm for treatment planning. Mm. It is if you're just trying to move teeth. Mm-hmm. or create a good bite, but just because you make straight teeth doesn't mean it matches the rest of the body.
Right. Or even just to settle for the face. It doesn't mean it matches the face much either.
Right. So the thinking that we use to create orthodontics entirely is almost, it doesn't even apply anymore. Mm-hmm. The underlying etiology, if it is epigenetic, if it is something that is new in human existence because of changes in our environment, and there are certainly plenty that we can document, mm-hmm. that just dealing with the symptom is totally inadequate.
So why do so many very intelligent people in our profession, not the point to name names, but there are many, who will say, it is entirely genetic. That is not debatable. It's a mom and a dad, and that's it. And I have heard some very smart people in our profession say that. Yeah. Do you think, again, it gets back to the orthodoxy where no matter what, the quote from Einstein or the fact that these people are not going to solve these new issues using the skill set they had in the past, so they're just unwilling to see this? Is it just kind of their own positive affirmation of their own existence and their own work in their own world? I mean, what is at
and do
the
I
core
blame
of that?
them? No, I do not.
Right.
We go through, what is it now, 12 years of schooling to get where we're going to go. We get out of school. We got loans to pay. Mm-hmm. We've got a life outside of our profession. We work hard. Yes, we may get paid well, but we bust our butts to create a successful practice. And now you're going to come along and tell me that this is not what I should be doing. Mm-hmm. I don't think I want to listen. And listen, I not only did I ignore these things before, but I'm constantly being bombarded with new thinking about the body as an electrical being, the ways that our bodies have to deal with toxic overload, the ways that our bodies are missing milestones in early development only to have primitive reflexes be maintained. And I'm going, oh, another layer in this rabbit hole. Do I really have to listen to this?
Yeah.
And I guess maybe I've been through it enough times. I slap myself silly and say, yes, you better listen. But there's that same reluctance to address these new things. And I totally understand it.
Yeah. Because especially the fact that doing it the traditional way doesn't directly in that moment cause harm. So there's no true negative consequence. We're Pavlovian. There's a stimulus response. And if that stimulus is negative, we are going to respond accordingly. Well, there's no real, just patient in a smile picture could look very good. And if you show them a before and after, 99.9% of the time, they're going to look better. We may look at it with our, you and I, with the way we think, and people who think like us and say, oh my gosh, they're narrow or they're this or they're that. But much like, again, that case I showed at Panny, it's like, by all sort of layperson standards, if you showed them his smile, they'd say, wow, look where he started. Look what you did.
Yeah.
I feel like if we could help people see, and I guess I pose this as a question, how do we help our colleagues see the negative sequelae which occur years and years down the road, because we don't see those patients on the regular for 10, 20, 30 years. And I know some orthodontists will say, oh, Mike, I have my patients come back to me at 20 years out for new retainers all the time. Maybe there's some outlier cases, but I practiced for 2 decades. There are very few patients that walked in my door who I had treated 20 years prior. It happens, but it's not the norm. So I think it's safe to say the vast majority of our patients, we don't see after 1 or 2 years after we finish their active treatment. So it's interesting that many of the people with whom I speak that are orthodontists, such as myself, such as you, also did some time in general dentistry. I spent 3 years moonlighting in my family's general dental practice while I was an orthodontic resident. And I don't know, it's purely speculative, that there's any direct relationship there. But there seems to be some sort of correlation between those of us who did general dental work outside of dental school and those of us who have a greater appreciation for the impact our treatment has decades down the road. So with that, I'll toss it back to you. There
were a couple things. One is because of our involvement in sleep apnea. And when I say our involvement, I mean dentistry's involvement, that we started understanding that drawing the jaw forward somehow opened up the airway. And why does that happen? I mean, we don't really think much about the tongue in dentistry except to get the damn thing out of our way when we're trying to do our work, right?
Right.
The idea that the tongue has not only the functions of swallowing, chewing, speaking, kissing, but that its very presence there in the mouth makes a significant difference about how well everything works. And so we started looking at the idea that this was not really a sleep problem, sleep apnea, as much as it was a breathing problem. That airflow itself can be a problem even when there's no desaturation. You don't have to have sleep apnea in order to have a breathing problem while you sleep.
Thank you.
And we have plenty of data on that now using high resolution pulse oximeters, or even, some of our
medical
wearables as well as
MRI and
all that stuff. We start seeing that there are problems with airflow. What are the problems with airflow? Well, the airway can get blocked. And even if it doesn't get blocked, it can be narrow. And if it's narrow, the physics of airflow are such that when there's narrowing in the airway, you just have to use more effort to breathe. And the more effort you use, it creates maybe like a micro trauma of the fluttering of the soft palate or the back of the tongue during snoring. And these are things that can get progressively worse, but they also have origins much earlier than the onset of sleep apnea. Mm-hmm. So now we're looking backward in the timeline. And when you start seeing where the narrowing comes from, you understand that a lot of it has to do with the fact that our skulls have not filled out the way they should. And they define really the outside borders of the breathing spaces from the tip of the nose to the bottom of the throat. Mm-hmm. If the face doesn't fill out the way it should, not only is there not enough room for the teeth, but there's not enough room for breathing either. Mm-hmm. And where does that come from? That comes from soft tissue dysfunction. Mm-hmm. That is, when you have trouble breathing, you now start to enter this vicious cycle where your compensation for not being able to breathe through the nose, for instance, by opening the mouth, changes the forces around the bones, that is the functional matrix, because I did have to read Moss after a while. Mm-hmm. It changes the functional matrix, and especially this maxilla, which is really a thin intramembranous bone when you think about it. It's a hollow bone. It's hollow because in the alveolus, all the teeth are taking up space. In the lateral portions, the sinuses are taking up space. In the central portion, the nasal cavity is taking up space. In the superior portion, the orbits are taking up space, so to speak, on the border. Mm-hmm. There's really not much to it, and it is so susceptible to these changes in function. And why do we have changes in function? Because we are struggling to maintain normal homeostasis and balance in the face of an environment that's entirely different than the one our genome was developed under. Mm-hmm. So, now the more you look at this, the more you say, oh my God, these things had to start at birth or before. Mm-hmm. And in fact, you can see evidence for that. There are congenital problems in the way the maxilla forms. A lot of preemies are born with these high, narrow palates, probably, along the continuum of clefting. There are tissues that fail to undergo apoptosis intra-uterine, like the tongue tie, the lip ties, and so forth. So a kid comes out of birth, a step behind to begin with. Mm-hmm. And even the process of birth, I've learned, is just as hard on the child as it is on the mom. Mm-hmm. And it's getting harder and harder on the mom because, not only are our faces not developing, our pelvic girdles are not developing the way they used to either. Yep. So now, what do you have to do with a child when they're born? How do you get them to develop well? How do you get them to breathe well enough so that they can breastfeed for 20 minutes at a time? Mm-hmm. How do you get their tongues to function well enough so that they can breastfeed and use their muscles properly? How do you get mom to be healthy enough to be able to breastfeed? And all these kinds of questions come up. Mm-hmm. It's not just the academic exercise of changing your orthodox beliefs. It's experiencing it in your own life that's going to start changing more and more orthodontists to think differently. And I've heard a number of them on your podcast tell those stories, especially the women, because the DDSs that have an MOM degree, they're really thinking about these things in very different ways.
Yeah, that was something I noticed early on. I remember having a conversation with Stacey Becker about this, and she was on. We kind of did some joint episodes of each other's podcasts, and I remember saying, Stacey, I feel like as I'm embarking on this journey of interviewing people and talking to more people about this, I feel like a lot of the female docs get it more intuitively than the male docs. I mean, there's plenty of male docs who have embraced this concept, but I feel like the women, there's just something in them that this makes more sense to. And I think what they intuitively sense as well, and this has been in the literature, Christian Guilleminault and Huang wrote an article, it was 2018 Sleep Medicine Reviews, where he talked exactly what you just said. This mouth breathing patients, it starts with just the mouth breathing, then it develops in this facial dysmorphism, more mouth breathing, this vicious cycle, and it's again Melvin Moss's functional matrix. And so the medical literature talks about this openly. Audrey Yoon had a great article with Doctors Kim, Journal of Clinical Prosthodontics, I believe it was, end of 2024, talking about this as well, where they said the role that we need to play as the orthodontist or any dental professional, which again, getting back to the moms, I think they intuitively sense is we need to break that cycle. And I think so many, especially of our orthodontic colleagues, especially the older ones, say, oh, no. Look, if they're going to develop OSA, they're going to develop OSA. And it's an on-off switch, right? They either have it or they don't. Right. If they're going to go that path, there's really nothing I can do. Right. That couldn't be further from the truth. And the evidence is coming out to prove that. And if you speak to our medical colleagues, they will talk about that significantly. Dave McCarty's great. He's actually on the show right around the time you are, and he speaks to that explicitly and talks about that fact. So I do agree that there is this sense that the moms have for this and the female docs have. And talk to that for a moment more when you talk about breaking the cycle. You gave some great examples of some of the insults that occur in our growth and development, even in utero. Sure. How can we then step in as the dental professionals? How can the dental professionals think about this to say, what can I really do about any of this?
Yeah, so I'll talk about the trajectory of my practice, which was 100% orthodontics. And by the way, I loved orthodontics, and I still do. I really like pushing teeth around. It's kind of fun.
Same.
It has rewards of its own. Mm-hmm. But as I start understanding what the etiologies of the problem are and were, I started moving towards younger and younger ages. Mm-hmm. And it was a little difficult in the beginning, especially because I was so enthusiastic about this that I would scare patients off in the beginning because, mothers would bring their kid in and say, I hate this front tooth. Mm-hmm. And then the kid would be in my chair and he couldn't sit still and he couldn't pay attention to me, and he was sliding off the chair, and he was talking to somebody else in the room. Mm-hmm. And I'm looking at Mom, I'm going, your child's really sick. Mm-hmm. She took him by the hand and walked out of the office.
Yep.
I had to learn a little bit how to talk appropriately about this problem. Mm-hmm. And it'll be easier in this generation of practitioners because socially we understand that people have a problem.
That's a great point.
I also lost all my general dental referrals, even the guys that were best buddies with me.
Yeah.
And still like me as a person, but they would send one patient over for straight teeth, and I would say, you have a breathing problem. Mm-hmm. You have a sleep problem. We're talking about muscle function. And they'd go back to the dentist and they say, I know you sent me there for straight teeth, but he's talking about all this crazy stuff. Mm-hmm. Well, that only has to happen one more or two more times before even my good friends thought I had flipped my lid. Mm-hmm. However, at the same time, I started making relationships with healthcare providers of other stripes.
Yes.
And so I was starting to meet speech therapists, lactation consultants, physical therapists, craniosacral therapists,
ENTs, allergists, and
ENTs, and allergists, and naturopaths, and sleep docs. And they were thrilled that they could find somebody that was thinking like them.
Yep.
Chiropractors, for instance, and cranial osteopaths, they've been thinking this way for 130 years. Mm-hmm. And they've been marginalized, especially as medicine took a turn for the biochemical directions that we did at the beginning of the 20th century. we have ignored parts of the body that are really very critical. Understanding this onslaught of chronic non-communicable disease is really important because nobody thinks that these things are genetic. You can't have this kind of increase in morbidity when genes just don't change that fast.
Correct.
Something else big is going on to humans on Earth now. And once you start to see it, you almost can't unsee it. And that's going to be true for orthodontists who start looking in their practices for kids that are sitting there in the chair simply with their mouths hanging open.
Yep.
I mean, once you see, right, Mike?
You're so right. I've actually been thinking exactly that with teaching residents, and I know you teach residents as well. And when I'm just lecturing to them about it, they kind of have the look of, well, I didn't learn this from anybody else. Maybe it kind of makes sense, but maybe, Barry, once they see it on their own patient and they start going through the screening process that people such as yourself and myself undertake, and then they start to ask the questions of the parent, they learn how to speak to the parent, as you said, which is another skill set we need to teach them, because it's not just about, oh, hey, we're going to throw some braces on in 12 to 14 months or 2 years or whatever the case might be, and they're going to look great. It's a whole different set of diagnostic and treatment approaches that you have to take when they do it and they see it and then they implement it, and 3-4 months down the road, mom's like, his teachers are saying that he no longer is acting out in class, and the neurologist just decreased his ADHD medication when they had been increasing it, and they can't believe the change in this child. And when I videotape him sleeping now, or they try to
explain it away themselves,
exactly. Or when I videotape him, he's no longer thrashing all over the place at night, and he's more of a quiet sleeper. And once they see that, to your point, they can't unsee it. And they, at that point, that becomes, going to what we said before, that becomes their orthodoxy at that point, because now they are all in on the fact that this is real. And I say this all the time. I really do believe we all go into this profession to help people. I really do believe that. I just don't think that people go into this with the thought that I want to hurt patients 20, 30 years down the road. I don't even believe that a lot of the people who we talked about before, who are of the mindset that what this conversation we're having, it doesn't have any place. I really don't even think they think they're hurting anybody. I think they've convinced themselves that that is the way to do it. Once you see otherwise, which I guess ties into the fact of why they do put blinders on, why they don't want us speaking at their meetings, and why they don't want to hear what we have to say. Once you see it, man, you're so right. You can't unsee this stuff. I
talk about this cohort of airway-centered disorders, and you think about it, these are things that we have struggled with in dentistry for many, many decades, unable to really solve, to the point where we start calling them idiopathic. We're the idios, by the way, by ignoring them. So they're things like frequent colds and allergies, tongue tie, open mouth posture, tongue thrust, and not just tongue thrust, but the soft tissue dysfunction of swallowing, like using your facial muscles to swallow. You're not supposed to do that. Those are compensations. Clenching and grinding, abfractions, erosion, all the kinds of ways that we destroy our teeth by subjecting them to forces that are just untenable for enamel health. Snoring, sleep problems, even fragmented sleep, finger habits, digital habits, compensations for growth issues, TMJ problems, hyperventilation, anxiety, terrible posture, head forward posture, and then just the icing on the cake is the crooked teeth. I did mention that there was a metaphor that I wanted to use that I thought would be helpful, which is the comparison between an interior decorator and a home builder. That, everybody wants their house to look great. And once it's built, you're going to pick the nice wallpaper, the nice curtains, the furniture, the artwork, all the accessories that are going to make the place look amazing. If you're trying to decorate a room on a house that has a crack in the foundation, then you may not be doing your client the best service by not mentioning that you covered up the crack with a piece of wallpaper. That the foundation really has to come first. Good square carpentry, the electricity, all the services have to be in place before you do your interior decoration. And there are interior decorators that are great at what they do. There are home builders that are great at what they do. You need both, right? But we're kind of dependent on each other and don't need really to be so critical of each other.
Yeah, and how often is it the case that we, as orthodontists, are trying to decorate that interior, so to speak, and knowing the foundation is completely off and knowing there's cracks anywhere. Again, this isn't an indictment or a criticism. Right. We actually, it's kind of what it's almost a badge of honor. Like, look, this was all completely in the wrong place and I was able to make it look good, right? Like that's a sign of a good orthodontist when you could do that. So we think, and that's the pervasive thought process. It's so true, but we need to step back and say, wait a minute. Where are these foundations? And I didn't do that enough early in my career at all. I look back at some cases and I'm like, oh my gosh, I completely missed it. I just gave a lecture recently to Dave McCarty's group. He's starting a group, Rebus, which has more of a comprehensive whole health approach out in Denver. And I gave a lecture to their group and I showed some examples of these happen to be adult females, that patients walked into my practice earlier in my practice before I understood and thought like we now think. Barry, I totally missed it. I was literally interior decorating. And I made their teeth look great, but they had deep bites, broken down dentition, dark circles under their eyes, looking back, very narrow airways. A lot of them had psychological issues, were on psychological meds. Missed it. No idea. Totally focused on the couch and the pillows and the carpet and the wallpaper, right?
Yeah, another wake up moment for me. I'm walking over to the chair. 15-year-old Carlos is in the chair for a retainer check. Okay. I had just finished his treatment 3 months before. And he's snoring. He's in the chair. His head is back. His mouth is open. He is snoring.
15-year-old kid.
This is in the middle of the afternoon. And I look over at his dad. I go, Dad, what's going on here? He goes, oh, yeah, Carlos has sleep apnea. In fact, he's supposed to wear a CPAP, but he refuses
to. Because you weren't asking, right?
I had no idea. I had just corrected a full class 2 malocclusion, corrected without extractions. I was as pleased as I could be with the results of this until I understood that I entirely missed the fact that he cannot breathe. And I swore to myself I would never let it happen again.
It's, again, a credit to you for being able to recognize those signs, because it could be really easy to just be like, oh, Carlos is a tired kid, he doesn't sleep well, or he's up on his phone on his device till 2 a.m, screen ager. He could have easily done that, and it's really easy to just say this isn't my lane and walk away. So I give you a lot of credit for doing that.
You start seeing these things and all of a sudden you put them in this context. It's a different way of thinking, and it all starts to make sense.
Yeah.
And once you see it, you can't unsee it.
Yeah.
So I personally am looking forward to this next decade of practice growth where I start bringing in, my ideal is a pediatric dentist who's a woman, a mom, has been in practice long enough that they're sick and tired of drill, fill, and bill, that understands that they want to help the human race develop in a better way. And if there's anybody out there listening to this, call me. I have a place for you in a progressive practice that needs your help. My staff is on my case. I can't carry the load. People are coming from stupid distances to get to me, and it's just the way things are.
Well, it brings up such a great point too, Barry, because I say all the time to young docs, they're so worried about the general dentist doing Invisalign. I'm like, why are you not understanding that the thing you should be concerned about is the general practitioners who are, and this isn't a slight to the GPs, they do it. I've had many on the show because we're not. So I actually really respect the fact that they're going and seeking the education and knowledge to be able to help these patients because they've had the experience of seeing it and can't unsee it. And they're like, well, I keep sending to these orthodontists and they won't do anything about it. So again, this certainly isn't a slight to them. But I say to the orthodontists all the time, you are worried about losing some Invisalign cases to a general practitioner. You need to worry about those general practitioners understanding everything that you and I are speaking about here in today and starting to treat these patients with a more holistic functional approach, getting ahead of it, helping these patients in their craniofacial growth and development and their neurocognitive and behavioral development because the parents are starting to wake up to this. They're seeking this service, right? So we're going to find ourselves as these isolated little tooth straighteners out there just treating the few patients down the road who didn't get this more comprehensive, proactive care. And we're going to lose what could be the biggest opportunity we have as orthodontists to capitalize on this subset of the population that needs us. Like, I can't tell you how many GPs and pediatric dentists I've spoken to who say, Mike, I don't want to do this. I would much rather the orthodontist do this, but they won't.
Mike, I'm so proud of you for what you're doing. I think you are ushering in a new generation of orthodontists who are open-minded, even if a little bit. And I concur. Orthodontists, you have such an opportunity here if only you take it.
Yeah, no, it's so great. So this has been such a fun conversation. How can people find you and learn about you, some of the courses you provide? Please share that because you are such a wealth of knowledge and have put so much time into just not only understanding this and implementing it, but teaching it. So how can people find you?
Well, thank you for that. My website right now is morethanstraightteeth.com. And I've been teaching these principles with Mark Cruz for, 8 or 10 years.
Okay.
And we're going to continue to teach. I have a course coming up for pediatric dentists. Limited enrollment, but we're going to do a lot of hands-on stuff. It is going to be so much fun. 3.5 days in July. My email is Dr. Barry, that's DRBARY. You can get this, alignmind.com. That's my legacy email. I could have gotten rid of it, but I just didn't want to change it from years back. ALIGNMINE.com. Write to me. Let's have a conversation. And especially if you're a young mom, pediatric dentist who wants to get into this. I'm like 12 miles outside of New York City. And I'd love to hear from you.
Oh, that is such an amazing opportunity for somebody. And I'll put links to all that in the show notes for today so people can reach out to you. And I really just want to sincerely thank you for all you do. You're such a wonderful ambassador. This is not easy what we do fighting this fight as orthodontists. Really admire the approach you take. Again, you're not coming out guns blazing, trying to fire off at all the orthodontic colleagues and say, look at me, look what I'm doing. You lead by example. You're open about your own failures and your own journey, which is really hard. And I mean it. I admire the fact that you were willing to step away from your orthodoxy. I had an advantage. I only was down that path for my residency and then the first year or two of practice. So I didn't have 25 years of doing it a certain way to undo. And that's just amazing. So I give you such credit for being a lifelong learner and trying to always pursue something greater. And your patients in the community you're in are blessed to have you there. I mean that.
Mike, you're making me smile. Thanks.
Yeah, I mean every word of it. It's just been an amazing conversation, Dr. Barry Raphael. It's an absolute pleasure. I'm so glad we've gotten to know each other through this, and I wish you all the best. And obviously, we'll be staying in touch. And if you need anything from me or anything I can help you with, please don't hesitate to ask.
Mike, thank you so much.
All right, great. Take care.
Bye, everybody.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.